Dear colleagues, welcome to this webinar at this Friday afternoon. I would like to welcome everybody. I want to talk about the ICX-Imperial concept and the system, giving us endless possibilities related to digital dentistry combined with implantology and also with immediate loading. So I would like to start with ourselves. I'm appealing from a dental clinic in a town called Waltrop, which is situated in the west part of Germany. And I'm a part of a big professional dental team with 30 professionals and also 5 clinicians. If I want to tell you the truth, we are very busy with implant dentistry and working since many years with implantology. To have an overview about my talk this afternoon, I will give an introduction to the main concept of ICX-Imperial, which is contributing to the future of dental implantology and digital implantology in many ways. Give some sample cases and summarize at the end of the presentation. As most of us might know, we are in the age of hurry, impatience, and also speed. And many of our colleagues are promoting treatments like fixed teeth in one day, new smile overnight, and use terms like fast and fix, immediate loading. Yes, we can achieve this goal, but there are some conditions which have to be there to be able to use this concept. We need good patient compliance. We need sufficient bone and good bone quality also, and eliminate risk factors. Our goal in this treatment would be a minimally invasive, automatic, and fast treatment, so that the patient's back to work or back to life period would be very short. But many of our colleagues have stayed very reluctant many years until very recently, because maybe they were skeptical of the results. We didn't have much experience to that time, and the prices were very high. But Medentis Medical has recently developed a congenial possibility to shorten drastically the time between implantation and insertion of the long-term provisionals. They developed a new concept and called it ICX-Imperial. The ICX-Imperial is mainly composed of immediate loading with a PMMA bridge on multi-abutments. It's also containing 3D planning, navigated surgery, and digital workflow related to it. It is mainly originating from the multi-concept, which was found in 2013. The ICX-Imperial concept can be used with edentulous as well as partially edentulous patients. As I said, the concept is built on multi-abutments. Multi-abutments are the screw-retained, occlusally screwed abutment type of the ICX system. It is designed for abutment level impression, so that means abutment remains in the mouth once placed. It isn't removed anymore, and for this reason abutment analogs are used in the model. It has a special impression coping designed for this purpose. And due all to this, it is easier and shorter for the clinician during the try-in sessions. It is also very patient-friendly because the abutment isn't removed in every session. There are three types of multi-abutments. One is the straight and two angulated abutments we have. One of them is 17 degrees, the other 35 degrees. Depending on the situation, the clinician can choose one of them. There are different heights of gingiva for different purposes. Namely, the straight one has 1 to 3 millimeters, and the angulated ones have 0.5, 1.5, and 3.5 millimeters. The abutment height remains always the same, it's 2.2 millimeters. This illustration shows also the same. There are three different multi-abutment types. But as you can see here, even in a 35-degree angulated implant situation, you have clinically the straight abutment looking into the mouth, so that you can work parallel in a parallel pathway, insertion way of the denture. There is the possibility to have with or without hex at the bottom of the abutment, depending on the preferences of the clinician. And important is to know that there are two different prosthetic copings, either the cobalt chrome or the titanium coping, delivered with the internal little screw for occlusal retention. This product is important too, I think, because as one of the few manufacturers, ICX delivers also weldable copings, which can be used intraorally for welding purposes. There are two different sizes of weldable abutments or copings to be used in the mouth. The treatment concept of ICX-Imperial relies on three legs. The first leg would be ICX-Magellan 3D treatment planning on CBCT images. It's a planning software which can achieve a lot for planning. The second one is the ICX-Magellan surgical guides. And the third is the ICX Smile Bridge, which is preoperatively fabricated individually with PMMA for immediate loading or restoration of the placed implants. So we can say that we need 3 appointments for the whole treatment. In the first appointment, we consult and discuss with the patient different treatment options, and if necessary, we can also make the impressions for study models and other purposes. The second appointment would be then the CBCT scanning, and followed by 3D planning in the Magellan software. And at the third appointment, we would be able to make the operation with the immediate loading. So we would, after the second appointment, order a package including the surgical guides, 3D models, implants, needed abutments, and the PMMA bridge. So we would be a complete, we had a complete package of all necessary material. So summarizing, there would be at the implantation day on the table following material: up to 3 surgical guides, a printed 3D model, all needed implants and abutments, and the smile bridge. I would like to go step by step through the procedures to have a comprehensive understanding of the listeners. It is important to mention that the ICX-Imperial concept or the system provides everything from A to Z. It gives us from planning software to provisional restoration, anything necessary during the operation. Once the generation of three-dimensional data is achieved, the DICOM data is in our hand. We would use the software for planning and matching of the images. So we would be able to place the implants while planning in the right positions exactly necessary for us in relation to the planned restoration, so that the emergence of the implant from bone would not disharmony with the restoration or the prosthesis. A 3D printed model can be manufactured looking at the DICOM data, and it is important to know that also the planned implant positions are transferred to the 3D printed model with the implant analogs, and the prosthetic copings are prepared too, because we know that otherwise we have longer to work to shorten the prosthetic copings, and the lab work would take longer time. So they prepare everything. An important part is the surgical guide. The 3D printed surgical guides with titanium sleeves would help the surgeon to place the implants exactly in the positions which were planned. And the PMMA provisional bridge, CAD/CAM bridge, which is called ICX Smile Bridge, is also manufactured, produced, and delivered to the clinic. It is important to know that the material which is used for this bridge is durable up to 6 years in service. So it's a good material which we can, as clinicians, depend on and use a long time in the mouth. At this point, I would like to give some example cases. The first case is a 4-on ICX mandible. It's in the lower jaw. You see in the beginning radiograph that the mandible is edentulous. There is good bone height, and in the upper jaw, opposing dentition is a telescopic removable denture. Again, the planning and matching is achieved, and the exact positions of the implants are planned prior to implant operation day. It should be harmonic with the planned restoration or prosthesis. For planning and matching, this duplicate denture which is prepared in the lab before the CT taking are very useful. And as mentioned before, the DICOM data is used to produce the smile bridge on the 3D printed model. You can see here the 3D printed model, the implant analogs, and also the prosthetic copings. The prosthetic copings, which exactly match to the multi-abutment, are prepared for height but are not connected to the smile bridge before the operation because of the possibility that there are some angular mismatches. We leave the option to be able to combine the smile bridge in the mouth after the surgery. Here's the situation after the surgery. You can see the implants and the multi-abutments mounted on the implants. The two distal implants are angulated to be able to be more distal. There is a safe distance to the mental foramina, and the middle two implants are straight. And this is the smile bridge, which is checked because of occlusion and then connected to the prosthetic copings in this position. The screw holes have to be closed. Mostly we use light cured Fermit material for this purpose. It is easy to remove later when we have to access the holes again. It is important to know that the tissue surface of the dentures should not be planned as saddles because otherwise we have this problem. The patient cannot clean underneath. So to avoid this, we need convex surfaces and very good polished surfaces so that the patient is able to clean, rinse, and access also the lower parts. The second case would be a freehand situation in the lower left, as you can see here. There is good interocclusal distance between the upper teeth and the lower alveolar crest. There's a question mark here because of the width of the bridge when you see from occlusal. But looking at the radiograph, we see that there's sufficient bone height. Again, planning the denture or stent is prepared with the matching balls. The 3D images are used for planning of the implant positions. They should be concurring and harmonic with the planned crown positions. And the DICOM data are transferred to manufacture the 3D model with the implant analogs inside. And on top of them, the smile bridge is designed and also delivered. This is the radiograph after the implant placements. You can see on the left hand side. And it is important to know that we avoid lateral contacts of the restoration, the provisional restoration, in order to avoid also loading, lateral loading during the osseointegration time. But 4 months later, it is possible to create a good occlusion. These are lithium disilicate crowns, screw retained, and the screw holes are closed with composite resin. It is not visible anymore, except the last crown maybe. And there's a third case where I want to show a maxillary 4-on ICX case. Again, the 3D images are obtained and the matching is achieved so that there's a possibility to plan the implant positions related to the restoration later. The bone volume is measured and the location of the implants are determined here. You can see here the planning software, Magellan, where the duplicate radiographic denture or stent can be seen and used separately. And you can see the relation of the stent or the denture to the bone. The exact implant positions, locations are determined and the planning is achieved and finished. This is the post-operative view with the multi-abutments. And this is the smile bridge, which is already combined with the prosthetic copings. And on the right side, you can see the screwed smile bridge. It is important to note that it is safer to have the smile bridge not combined with the prosthetic copings, because the prosthetic copings should have a gap between the coping and the smile bridge, so that we can have the possibility to have a passive fit and combine in the passive fit situation. It should be mentioned that also the connection should be achieved in occlusal position, so that the denture is in real best occlusal position. And the screw holes are closed with some material which can be easily removed later. In our case, we use the light cured Fermit material. The same case I would like to show you as a movie, because it will be very comprehensive to see it. We start with the surgical stents in position, as you can see here. The surgical guide in position, fixed with 3 pins from different points, so that it is fixed in the maxilla. And while the surgeon is working, it should remain always at the same position. The surgeon can work flapless, making the drilling as well as the implant placement through these holes. It is very atraumatic. Here you can see that the surgeon is placing the implants, the last placement, the last piece of placement he's doing by hand, by torque wrenching, and seeing the stability of the implants, because it is important. If you make a immediate loading, the stability should exceed at least 35 Newton centimeters. If we don't achieve at least 35 Newton centimeters, we should think about not loading the implants at this session and wait for osseointegration. Each implant which is stable over 35 Newton centimeters is suitable for loading. This is the bone profiler. the implants are already in place, the bone profiler is useful in making the bone suitable for the placement of the multi-abutments. Especially in the angulated implants, it is important to use the bone profiler so that the abutment is sitting well. I should mention at this point that also the multi-abutments were determined in the planning. So we knew which multi-abutment to use in which place. Most of the time, if the implant position doesn't deter from a lot from the original planned position, we can use the planned multi-abutments. This is the direction pin of the multi-abutment so that we can see the direction of the abutment, making it easier to compare with the neighboring implants. As you can see, after placement of 4 implants, the situation is really very atraumatic, very patient friendly. The multi-abutments are screwed in by hand, and once we are sure about the positions, then they can be torque wrenched too. They should be torque wrenched with 27 Newton centimeters. The direction pins show exactly the direction of the multi-abutment, the upper part of the multi-abutment. The screwdriver is in the direction of the real implant direction. So you can see that the implant is angulated really distally. Also here you can see the direction of the implant. They are hand tightened and the direction pins are controlled, whether they are in the position as planned. Now, since we don't need them anymore, the direction pins are removed. As mentioned before, they must be torque wrenched with 27 too. And now it's time to try in the smile bridge. But first, the prosthetic copings should be screwed in. The prosthetic copings should be hand tightened because they will be removed one or twice. Final seating could be made by torque wrenching. And at that point, 22-23 Newton centimeters are advised. The whole treatment was achieved by my colleague Andreas van Orten, and you can see how easy and untraumatic the whole procedure was. And it is quick too. Once the prosthetic copings are in place, the smile bridge will be tested again. If it has a passive fit, it is ready to be fixed. If not, there still can be some material removed from inside so that the copings don't have any contact to the PMMA material. It is also important to close the screw holes with some cotton or similar material because we want to avoid resin material to come inside the screw. It's not easy to remove later. Now, once the prosthetic copings are torque wrenched, the bridge is ready and the holes are closed. The bridge is controlled in terms of occlusal contacts. It should be good contact everywhere. we should avoid pre and at this point we use an autopolymerizing resin. In this case it was Q resin from Referent, but it can also be another material. It will autopolymerize. Important is after putting this material around, it is important that the patient is waiting in a biting position. Some clinicians also can prefer maybe light cured materials. It's also possible. Since it is without any metal framework, it would work too. And now it should be removed again for final corrections and polishing. Most of the time the screw holes are obliterated with the resin. They should be removed. So that the screw holes are accessed again. You can also use Teflon tapes to close the holes. If you once plug the Teflon tapes, no excess resin can enter screw holes. Now the smile bridge is removed for the last time, hopefully, for the next months, in order to polish. Since the surgery is flapless and the bridge is ready before, in a very short time we can achieve 4 implants and also the immediate loading. It doesn't take long. It is very comprehensive, understandable and easy. Usually, if everything was okay, 12 to 16 weeks later, we should have this kind of healthy soft tissues and also a good osseointegration. Once we have achieved this, now it is turn for the final denture, which was planned. Now we have to make impressions. For this purpose, we take the impression copings designed to put over the multi-abutments. Important to know is if there are angulation differences between the implants, in this case, so we need the open impression technique. And for the open impression technique, most of the time individually made trays are suitable. I would recommend individual trays. And very innovative product of ICX implants is also this protection sleeve put on the impression copings. It makes life very easy for the clinicians because it protects the screw holes, access holes from impression material. And it is easy after the setting of the impression to remove them and access the holes of the copings. And the impression would look like this, and this is from the bottom. As you can see, the protection sleeves removed and the excess holes of the copings are easily seen. Sometimes we need the pattern to fixate the impression copings and protect from moving in the impression. It gives us security. At this point, I would like to show a short movie about our try to make digital impression of the same patient. Our goal was to achieve a digital impression which took about 1/10 of the time of the conventional impression. If you consider that we need the individual tray and also model making, model casting, if you consider all of this, the digital impression is much quicker. But it has still some disadvantages and it should be developed more in the future so that we can have a full digital workflow from A to Z and don't have to deal with the conventional technique anymore. So at that point, I would like to summarize everything we talked about. We talked about the ICX Imperial concept developed by Medentis Medical to give us the opportunity to have a full package of digital workflow from planning of the CBCT images to surgical guides, making life easier for the surgeon and for the patient, and making possible the placement of implants exactly in the planned positions, thus making a prefabricated bridge or denture possible, and they call it Smile Bridge. So it offers a wide range of alternatives for all immediate loading situations. And digital innovations of Medentis Medical are gathered under the name ICX-Imperial. And with this, I would like to thank all of you for the time this afternoon, and would like to give my information to you so that if there are any questions later, they can ask me and I'll do my best to answer them. But since we are connected, I would like to get some questions now. If there's anybody wanting to ask questions, I'm here. Thank you very much. And I wish you a perfect weekend.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.